is by far my favorite picture in all of orthopedics. This guy on the left here. It's from Paley's like the pediatric deformity app, but it gives you on one side the mechanical axis and the other side the anatomic axis. And it is like of paramount importance when you're fixing plateaus, particularly the bicondylar one, because you're basically trying to recreate alignment. And whenever you're in the OR, your attending is going to be like, what's the most important thing we're going to do? And it's reestablishing the coronal alignment. And it's really difficult to do that if you don't know what coronal alignment should be, because you're looking at a small fluoro shot of a smashed bone, and you're making it whatever you want. So 81 degrees of the femur, 3 degrees of varus on the proximal tibia, and 10 degrees of slope. Important for your fixation, but also important for obtaining your x-rays. You're going to see this all the time. We tilt the x-ray 10 degrees to shoot down the plateau and get that nice crisp picture. Makes you look cool in the OR. So that would be how you shoot the x-ray. They'll also ask this one. We're going to talk a little bit more about fluoro afterwards, but when you look at that lateral image, you're looking for the convex lateral side and the concave medial side. And then people love to ask Tim questions about the differences between the two plateaus, the dish versus the dome, larger meniscus on the smaller lateral side that helps absorb more force. You have a lot of rollback on that lateral femoral condyle, so it's also a mobile meniscus. All of this is more important for the sports world. The important thing is that you cut underneath it to see to the plateau. Shatsker is a great Canadian. He's from my program, and he's like probably the most famous person from Toronto. He actually hates his classification system. I don't really know why. He's kind of a strange bird to talk to, but he's obviously very, very renowned. But we still use it. I think the biggest hit against the Shatsker classification is, number one, it's based on X-ray. Number two, it's based on AP X-rays only. So all we're seeing with this is your coronal plane. So that's why it's all split depression, all that jazz. And so in the age of CT scan, people have started to talk about how the Shatsker classification is kind of inadequate for characterizing fractures, and we'll talk about that on the next slide. But what he did introduce with this, and I think why it gained so much traction, is because it actually does help guide your management, and it helps you think about the injury. So if you broadly think of the Shatsker classification, it's going to put you into these three categories of mechanisms. You're going to have the valgus failures, the varus failures, and axial failures. That's kind of your lateral, medial, and bicondylar smashes. And if you start to think about that mechanism causing the fracture, then you're going to start to recognize the associated injuries. And part of the game here, the emergency management of tibial plateau fracture is pretty important, because you'll oftentimes find that you'll get consulted. Like if you look at that middle picture and you look at that medial plateau fracture, lots of comminution, or to our eyes, we see a lot of comminution. And I would hope that anyone here would recognize that is an emergency and that's a bad fracture, and it's actually a knee dislocation. So that completely changes your management. And I've seen these patients get sent home from the emerge just because it doesn't look like a terrible plateau fracture. They put it in a splint and it's in reasonable alignment, but truly that needs to be worked up very closely and kept overnight for monitoring. So recognizing these mechanisms is important. You'll get pimped on questions where in valgus failures, how much increased width and depression is going to cause a lateral meniscus fracture. In general, plateau fractures all have soft tissue injuries. So there's a Gardner paper out there that did an MRI on all of the plateau fractures, and they saw 91% had some soft tissue element disrupted. So either a ligamentous structure or like patellar tendon or something like that. So it's the exception not to have a soft tissue injury. So this is what I was referring to. This has not gained any traction. for obvious reasons, but this is a combo new classification system called the Shatsker. Kafuri is a Missouri guy. He talked about how the CT scan needs to be used to evaluate these fractures so that we can appreciate the sagittal plane fractures. Basically, just look at the lateral and see where they're exiting, so that we're no longer just talking about splits in the coronal plane. So he proposed this super complex method of nomenclature where you talk about where the fracture line enters and exits and where the apex is. But really, the concept is important, the nomenclature less important. The concept is that we divide the plateau into anterior and posterior, medial and lateral, and we decide where those fracture patterns are predominantly. And I think you can even simplify that even further and just think about where the metaphyseal apex is. So if you look at the bottom right corner here, that AX, that just means anterior exit. Anterior metaphyseal exit, and then PX, you'd have a posterior metaphyseal exit. And all this is saying, all of these fancy nomenclature things is saying, where is the spike? And with that, you're going to do the classic orthopedic thing. You're going to find the spike, you put your thumb on it, and that's your buttress. So it's a really complex way of getting to a concept that all of you already have, and that's how to buttress bone. So when you're evaluating the imaging, I'd say this is like kind of a rough breakdown of how I go through it. Number one, you need to recognize the red flags. That's like the entry level, because you're going to get phone calls about tibial plateau fractures, and you need to know which ones are bad and which ones are okay. And then when I start to think about these, number one, I look at the overall alignment of the limb. Number two, you're going to look at articular involvement. You're going to start to characterize where your main fragments are, where your comminution is, and where your intact joints, if any, there is left. And then, like I was referring to earlier, you're going to look at the metaphyseal extension, both where you're going to have exit points, but also how far down that metaphyseal extension is, because that's going to dictate the length of your plate. And then primary fracture fragments and location, that's what I was just saying. Ligamentous avulsion. It's like more of an advanced thing, and we're not going to really talk about it today, but there's a spectrum of tibial plateaus. And so at one end of the spectrum, you have a total knee dislocation with no fracture. And then as you have more bony contact, as that femur exits the tibia, if you have more bony contact, you're going to get more fracture. So you're going to start seeing rim fractures, and then you start seeing larger chunks come off with the femur. And so there's a spectrum of where is it a tibial plateau fracture predominantly, and where is it a knee dislocation predominantly. And so you need to recognize those subtle differences. And I mean, it's not crazy important. You just need to know that you need to recognize whether it's a reduced joint or not. But you can start to see subtle things like ligamentous avulsions that will tip you off to this being more in the camp of ligamentous knee injury. The big ones that you have to recognize for acute fractures are tibial tubercle. That's number one you have to find. And then PCL facet also is a little bit of a hot topic to find as well. So these are the big red flag things. You want to look for bicondylar patterns, tons of comminution, open fractures, distal extent or separate fractures. Oftentimes you'll see people with shaft fractures and plateau fractures. The most common combo, and that's another hot topic for conversation, is proximal tibia fractures with plateau extent. So is it a shaft fracture with a plateau or a plateau fracture with a shaft? That's for another time. The importance of recognizing that they're high energy is that you need to rule out the associated injuries. So you got to look for compartment syndrome, open fractures, neurovascular injury, and ipsilateral fractures and whatnot. Okay. So somebody talk to me about the lateral plateau findings in this one. Who should I call? I'm sorry, I don't really know all you guys. But let's go for a 2.
Okay, this is Sarah. I'll talk about it. I think that what you see here is You see a split with a metaphyseal exit point with some depression as well. I think there may be 2 exit points actually, so 2 lateral plateau pieces with some depression.
Yeah, so what, can you see my pointer at all?
Yes.
Yeah, you can? Okay, perfect. What's my pointer on right now? What's that?
That is a contour of the articular surface. I'm trying to figure out if it's anterior or posterior because you see 2, I think.
Yeah, you see 2. So there's this one here too.
Mm-hmm.
So if you had to bet, where do you think this lower one is, this depressed joint surface?
Probably anterior.
Yeah, probably anterior. The most common split depressions are anterior. And then this bit here, posterior, that's your intact lateral plateau. So the difference between that and that is your joint depression. What else do you notice in this lateral compartment? It's tough to see the metaphyseal exit point. I imagine it's there. It's got to be there, but I can't really make out exactly where it is. It's probably somewhere around here.
Yeah.
What about this business right here? What's
so
that?
I think it's widened.
Yeah, for sure. Totally. I got some fancy stuff to show it. What is this, a Shatsker 3 or a 2?
I would call it a 2 because I think there's a split fracture line that we see.
Yeah, that's like a trick question. Shatsker 3s arguably don't exist. There's and they don't exist because of this phenomenon exactly. When he did his description, he only had X-rays, and he couldn't really see metaphyseal exit points, so he may have called this a Shatsker 3. Nowadays, when we have CT and MRI, every single fracture has, even at the minute level, a coronal fracture plane. So there's this controversy as to whether, I mean, it's not even a controversy. It doesn't really matter. We all treat these the same anyway. So, but yeah, S3s don't really exist. But you got it bang on. So we'll talk about condylar width afterwards, but there's your joint depression. There's your increased condylar width. Okay, what about this one? We're going to bump this one up to a 3. What part of the joint's depressed in this one?
Hey, all right, I'll take this. So looking at this lateral, it's a little blurry, but what I think I'm looking at is that I see a concave surface that's involved. So my guess is that the medial plateau is involved on this one. That's what it looks like to me.
Totally involved. I'd say, so this is our concave surface. You see my mouse there? That's the front part of the joint. And then you see this a bit of comminution there with a little line going posterior. I'd say that's the medial portion of impaction. But I'd say the more substantial area of
it's also lateral, yeah.
See that line there? That is your convex surface that posteriorly is pointing downward. And it's pointing downwards along with this spike. So if I was a betting man, I'd say that this is a posterolateral split that has dropped down. The more important thing to recognize in this, because you're going to get a CT on this and you'll be able to look at that depression, but the most important thing actually to find on this X-ray is this right here, your tibial tubercle fracture.
Tubercle off.
Those things, and I have done it personally, missed a tibial tubercle fracture, you fix everything, you put a ton of plates on it, and then you don't see it on X-ray because you've now hidden everything with plates. So if you're not super critical of where your fragments are, you can miss that. These things are covered by about 10 angstroms of skin. So the minute it lifts off a little bit from your patellar tendon, you get instant necrosis of the skin overlying that, which has happened to me. So there's your tibial tubercle fracture. There's that metaphyseal split on the posterolateral side, and that's what we're seeing. Okay, let's send this one up to a chief. Where's I haven't met Erica Roddy yet, but I feel like I run into like 1,000 papers with her on on this, so she's like the preeminent expert on tibial plateau fractures, and I feel like she should be given this talk. But maybe we'll get her to weigh in on this one.
Hey, can you guys hear me?
Hey, yeah. So what do you, if you're looking at this, what do you think of the primary fracture fragments that you have to buttress?
Yeah, so I see three main ones. I mean, there's the classic posterior medial one, there's a lateral one, and there's that like anterior one. So I think you have to buttress the posterior medial one for sure, the lateral one, and then I might put like a little, well, then there's the tubercle. So, I would put a plate on the front as well.
Yeah, the plate on the front. I agree with that. So bring up a little fancy thing here. So posteromedial, classic fragment there, apex posterior. That's one that needs buttressing. Anterolateral also has a metaphyseal apex that's exiting. You can see circled there. That needs buttressing. But that anterior piece is not a classic shear fragment that's come off. That's kind of a component of the central comminution. You can see it doesn't really have a shear metaphyseal exit. So I would agree. I would plate this just to give it some extra fixation because it has large fragments attached to it, large joint fragments. But I don't think it necessarily needs a buttress. Okay, what approaches would you use, Erica?
It's a good question. I think the anterior piece is a bit more on the medial side. So I'm just wondering if you could get to that via your, medial versus lateral approach. But I mean, I would use dual approaches.
For sure.
Obviously. And I think, you could probably just, I think you could probably get to the anterior piece by just raising a skin flap from your posterior medial approach. So probably posterior medial with the skin flap anteriorly, and then your classic anterolateral approach.
Yeah, I would totally agree with that. So anterolateral approach definitely, because we need to access this apex to buttress. So that's going to be number one for buttressing. But the other thing that's the benefit of the anterolateral approach is that it's going to be your main viewing point. You're going to, number one, do a submeniscal arthrotomy, which is going to help you see the joint and line all this jazz up. But you see where my line is coming through here, just that's going to be your view in your anterolateral portal. So you're going to be able to see right into that fracture. So you can deal with that comminution, you can temp some stuff up, and you can try and fandangle that anterior piece back into place. Posteromedial, 100% you need for fixation. It's not going to give you much in terms of visualization, but you do need to buttress this, so you need a posteromedial approach. How to access this anterior bit is controversial. I mean, you're going to get 100 answers if you ask a bunch of surgeons how to do this, but I do like your plan, elevate a flap, because you can make your posteromedial approach, you can, it's a very mobile window. And if you made it more medial, you're going to have no problem getting a plate posteriorly and getting some fixation into that anterior fragment. So I'd probably keep my posterior medial approach a little bit more anterior because I know that I'll still be able to get a plate here and give me a little bit of view into this fragment here. But yeah, that's 100% what I would do. So basic stuff for how you're going to manage these after you recognize the imaging and go through it is this emergency management applies to every single plateau you see, whether you think it's high energy or low energy. You need to make sure that there's nothing else going on, treating the open wounds, reduce and stabilize the joint, and then monitor them. It's the exception that these patients go home. They should stay in overnight at least. Non-operative management is pretty unusual for plateau fractures. They need to fit some pretty strict fracture criteria, and then also your patient's characteristics that are going to make them non-operative candidates. Like I was saying, try and figure out which ones are the low energy, which ones are the high energy. It's going to help you with your workup. It's going to help you with your emergency management. And then it's also going to help you with your operative management in that soft tissue here is a real problem. So the number one thing with plateaus is respecting the soft tissue envelope. So you need to decide whether or not to fix it acutely or fix it delayed. Same controversy with Plafond fractures. So when in doubt, you should be X-fixing these with a knee spanning X-fix. We won't talk about that, but that's a great talk in itself. Okay, so these are my surgical principles when you're treating a tibial plateau operatively. I'd say I've tried to list them in order of what I think is important, and with the caveat that I would probably revise this and put protect the soft tissue number one. So number one, respect the soft tissue. Number two, correct the coronal alignment. Number three, give them a stable construct, stable enough to get their knee moving. And then the last one, which we spend the most time doing, but I would argue are the least important, are reducing the condylar width and restoring the articular congruity. If you do these two things perfectly, you will have ticked off alignment and stable construct inherently, but I wouldn't agonize over getting these perfect. You need to focus more on getting the alignment and getting a stable construct built. And definitely don't compromise soft tissue just to get a little bit better articular reduction. We won't go into full detail of all the approaches. Definitely important to know all of them. The workhorses are the anterolateral and the posteromedial/medial approach. The rarer approaches that you use are the direct posterior, the posterolateral, and if you're really lucky, you do a transfibular osteotomy and get about 3 millimeters extra view, which will make all the difference. And then there's some proponents for a direct midline anterior approach. And this is when we start getting into the talk of whether these should be replaced or if there's replacement imminent. This was a cool picture depicting what you can see from your various posterior approaches. So posteromedial, you can see, actually gets you quite a bit of visualization. And if you do identify one of those PCL facets, you can actually fix a PCL facet through a posteromedial approach. Your reduction tools, the tibial plateaus are super fun to fix because you essentially have all of these bags of tricks that you're going to use kind of as needed. So you have them all available and you're going to kind of throw them in as you need them. But the classic ones that you're going to see, lots of K-wires, lots of bone cams, femoral distractor is your friend. You can combine them or you can use something like traveling traction that helps with your coronal alignment and distraction, and then large periarticular clamp and using your plate to help you get a reduction. This is an important concept about getting perfect fluoroscopic images. Alex, what can I do to my lateral image there to make it better?
Yeah, so if I'm looking at your lateral image, you generally want some overlap between your fibula and your tibia. I think the overlap is slightly too much, as well as the joint surfaces aren't fully aligned.
Yeah.
And so you'll probably do like a little wag to align your joint surfaces better, and maybe a little extra rotation as well.
I would argue just rotation.
Okay.
So I did this view. This was the last plateau that I did with Dr. Marmer, and we did this view intentionally because it gives us a perfect view of the two joint surfaces. You can see them there in the medial and the kind of flat lateral. But the X-ray is not a perfect lateral, and the way you can tell is that you have this little bit of difference there. If you have difference in the posterior condyles, that's rotational. If you have difference in the distal condyles, which there is none there, that's wig-wag or abduction-adduction. That's how you can fine tune your lateral images, just based on those two locations. So if I wanted to make this perfect, I'd probably internally rotate that leg a little bit to take away this overlap. And then my AP image looks pretty good there. You want the fibular head bisected. And this is a 10-degree slope, and you can tell because of the crisp joint lines. That's number one. You need to be able to get perfect imaging before you can even think about trying to judge your reduction. So number one, fluoro. Number two, when possible, you should do this under direct visualization. So this is your lateral submeniscal arthrotomy. You got to be careful how far extended posteriorly you're going with this, because you'll start to hit your LCL. This is a nice example of what you can see. It's pretty limited in what you can see, but and especially when we start talking about medial side fractures, you can't do a submeniscal arthrotomy there because of the attachment of the MCL. So you're stuck with using things like indirect reductions and fluoro. There's some crazy people out there who are mixing scopes with Tibial Plateau. I actually don't think it's that crazy. And I think it's probably something that we're going to start seeing a little bit more, but people will stick dry scopes in here to see their reduction. This is a comment on restoring condylar width here. So this is just how you can measure it. So I don't know why they didn't line these up, but point A, which is the lateralmost portion of the articular surface of the tibial plateau, should line up with point B, which is your lateral epicondyle of your distal femur. Okay, and then so you have a bunch of tools that you can use to help you with reduction, and you have a bunch of tools to help you with fixation, and you're going to see a lot of terms thrown around in tibial plateau fixation. So number one thing is buttress plates. So a buttress plate is taking that shear force and converting it into a compressive force. Classic AO stuff, but we're going to be using that all the time. You're going to hear about raft screws, which are basically just a mesh of screws that you're putting in that helps hold up or raft up little tiny bone fragments. And that's how we keep our little articular giblets from dropping down and subsiding. That's all rafting is. You can do it with screws, you can do it with wires, you can do it with separate screws outside of your plate. But essentially, you're just making this mesh of screws to stop your bone from subsiding. Locking versus non-locking, classic debate, classic question. There's no real answer to this. The idea of a locking plate mechanism is that you get a fixed angle device. So you get a rigid diving board. So if you were to put weight at the end of that screw, you're dispersing that weight across the whole length of the screw and into the plate. Whereas if it's not locked into that interface and you stand at the end of the diving board, you're putting all that stress through the plate bone interface. The argument is that, do we even need that in partial articular injuries where your diving board is being held up by the cortical bone on the other side? And in bicondylar plateaus, do you even need it because you're putting dual plates to buttress everything up? So likewise, your diving board has support on either side. So stay tuned on that one. And then you'll hear about things like filling the defect or containment and open book. Essentially, they're just techniques to help, again, prevent subsidence of that bone. So opening the book is where you literally book open your fracture fragment, elevate your joint fragment, and then put something in to prevent subsidence. You see a nice picture of it there. And then this containment technique is essentially where you get a provisional reduction of the peripheral rim of your plateau, and then you leave that area depressed within it. So you've now contained the defect, and you make a little cortical window like they have here. That's definitely not where I would make the cortical window, but that's cool. And then you tamp it up, and you have this plate that helps contain that tamping action. You can actually see this top picture here is the great Dr. Satariano elevating a joint line, and it looks mint. So you can see on the left side, you have that same depression that we were talking about earlier. And on the right side, after his tamp went in, you got a perfect joint. So this is containment technique 101. Tibial plateaus have a lot of complications. We're not knocking these ones out of the park by any measure. This should say, I think the infection rate, it's obviously not 43%, but I think it's 12% overall have infections, obviously more common in open fractures. Stiffness is a big issue. Non-union and malunion are relatively common, including intra-articular non-union. And then post-traumatic arthritis, you're gonna hear kind of two camps of people who say 7.3% isn't that bad, or you're gonna see people that say 7.3% is bad. If you look at the literature, so this is a paper also out of Toronto that looked at, we have this database where every single person gets loaded into, whether you got treatment anywhere else in the province, you're all in the same database. So it's good follow-up in that we took all the people who had their tibial plateaus fixed and we followed them for 10 years. And it doesn't matter where they got their surgery, if it was in like Timbuktu versus in Toronto, we would know whether they got a total knee. So we took all those people, we followed them for 10 years, and we determined who got a total knee replacement. And that's where this 7.3% comes from. That's at 10 years, the plateau fracture cohort, 7.3% had total knees put in versus 1.8 in the general population. So yes, that's not a crazy number, 7.3, but it's significantly higher than your general population. The modifiers that made it higher risk were age, bicondylar pattern, and medical comorbidities. Some other important ones that seem to always come up in OE and come up in OR concessions, but this is the paper that everybody gets the malalignment being a big issue from. So malalignment outside of 5 degrees was associated with higher rates of OA development, pretty substantially higher rates. This Gardner does a lot of research into the soft tissue injuries around plateau fractures. He was the one that found that like all of them have some element of soft tissue injury. But he did this study that looked at the amount of depression and the amount of widening associated with meniscal injuries. So you have 83% chance of having it if you're above those 6 and 5 widening and depression. And then you'll also hear about what should we use to fill the bone void. So articular subsidence was, is being studied with different graft types. And right now, this Ross-Layton study showed that there was higher subsidence in the autograft group versus the calcium phosphate group. And then the argument over phosphate over sulfate is that sulfate resorbs quickly, which is not really what we're trying to do if we're trying to prevent subsidence. So that's why we're in the phosphate camp. And then this last paper, which I think, Erica, you can correct me if I'm wrong, but I think you're like an author on this or some kind of contributor to this. But it looks at surgical site infections with ipsilateral compartment syndrome. And essentially it's saying kind of what we know from all of our other trauma literature, that you want soft tissue coverage reasonably quickly. So infection rates are going to be higher in compartment syndrome with tibial plateau fractures, which is not surprising. And then delays to closure also increase your likelihood of surgical site infection. So you should be aiming to cover your metal as soon as you can. And then we won't talk about these things, but super interesting topics to get into. There's a lot to talk about with tibial plateau fractures, whether it's a multi-leg, whether it's a shaft, if we should be replacing them all for all you arthroplasty surgeons out there, what to do with non-unions, but